This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Croatian Medical Journal, published in 2026. It's a case report titled Craniospinal Cerebrospinal Fluid Volume Changes After Extreme Bilateral Frontotemporoparietal Craniectomy and Cranioplasty, a volumetric magnetic resonance imaging case report.
This is a particularly interesting read, Alara, because it touches on a scenario we occasionally see in the trauma bay, but rarely get to analyze with this level of physiological detail. We're talking about an 18-year-old female patient who underwent a truly extreme bilateral decompression.
Exactly. The patient was a pedestrian hit by a tram. On admission, she had a left frontotemporoparietal, or FTP, acute subdural hematoma with extensive skull base and calvarial fractures. After the initial left-sided craniectomy and evacuation, she developed a 20-millimeter thick right-sided epidural hematoma the very next day,
which necessitated a second FTP craniectomy on the right, so she was left with a massive bilateral skull defect. What makes this case a natural experiment, as the authors put it, is the subsequent development of a pronounced bilateral sinking skin flap syndrome.
Right, and for the residents listening, that's often called the syndrome of the trephined. The authors describe it here as an atmospheric pressure-driven collapse of the cranial compartment. Because the rigid skull is gone, the brain is no longer protected from atmospheric pressure, and the cranial compliance is abnormally increased.
It's a pathophysiological nightmare, but what's unique about this paper is how they tracked her recovery. Usually, we just look at the CT to see if the brain has expanded after cranioplasty. Here, they performed full neuroaxis 3D craniospinal imaging, measuring both the cranial and spinal compartments before and 3 months after she received custom implants.
The volumetric data is the real meat of this study. Let's dive into those numbers. Before the cranioplasty, while she still had the sinking skin flap, her total craniospinal CSF volume was 179.0 milliliters. That was broken down into 100.8 milliliters in the cranium and 78.2 milliliters in the spinal compartment.
And then they brought her back 3 months after the bilateral cranioplasty. What happened to those volumes?
It's a significant shift. The total craniospinal CSF volume jumped to 243.7 milliliters. That is a net gain of 64.7 milliliters of CSF. Specifically, the cranial CSF increased to 152.7 milliliters, a gain of about 52 milliliters, and the spinal CSF increased to 91.1 milliliters.
So we see a global expansion of CSF across the entire neuroaxis once the cranial boundaries are restored. But here's the kicker. Did the brain parenchyma volume change?
That's the most important part. No. The authors noted there was no relevant change in brain parenchyma volume. The patient didn't have hydrocephalus or new mass lesions. This increase in CSF volume wasn't due to the brain shrinking or ventricles blowing out. It was a redistribution and expansion of the neurofluids.
This is where the paper gets into the why, and it challenges how most of us were taught CSF physiology in medical school. We're all familiar with the classical hypothesis. CSF is secreted by the choroid plexus, flows unidirectionally through the ventricles, and is absorbed by the arachnoid villi into the durosinuses. It's essentially a plumbing model.
Right, the bulk flow model. But the authors argue that these volumetric findings, specifically the large net gain of CSF after simply closing the skull, are difficult to explain with that traditional model. Instead, they point toward the Bullitt-Clarika-Oreskevich hypothesis.
I remember reading about this. This contemporary hypothesis views CSF, intravascular fluid, and interstitial fluid as a single hydrostatic and osmotic capillary-driven system.
Exactly. In this view, CSF and interstitial fluid form a single neurofluid system governed by capillary filtration and reabsorption along the entire craniospinal axis. It's not just about production and drainage at specific sites. It's about a continuous exchange across the capillary walls.
So apply that to our patient with the sinking skin flap. When the skull is open, the cranial compartment is exposed to atmospheric pressure. In the upright position, this shifts the intracranial CSF pressure toward atmospheric values. This drastically changes the pressure-volume relations of the craniospinal axis.
And the paper mentions that previous animal models showed that a bony skull defect preserves the overall CSF pressure gradient, but shifts the values. By performing the cranioplasty and restoring the rigid boundaries, we transform the system back from a partially open one to a closed rigid one.
Which, according to the Bullitt-Clarika-Oreskevich hypothesis, allows for this global redistribution and expansion. If the system is capillary-driven and based on hydrostatic and osmotic pressures, then restoring the box of the skull changes the filtration and reabsorption balance across the whole system, which explains why even the spinal CSF volume increased by nearly 13 milliliters.
It's a paradigm shift. We've always known that patients with syndrome of the traphind get better after cranioplasty. This patient, for instance, finished high school and entered university after her surgery, but we've often struggled to explain the exact mechanism beyond just releasing pressure.
This study suggests that quantitative cranial spinal volumetry can provide in vivo support for these contemporary concepts. For the residents listening, why does this matter for your daily practice? Why do we care about the Bullitt-Klarica-Oreskovic hypothesis?
Well, for one, it might help guide the timing of cranioplasty. If we understand that the bone defect itself is an independent pathophysiological factor, even when the intracranial pressure is technically normal, it pushes us to restore that cranial integrity sooner to normalize neurofluid distribution.
Precisely. Decompressive craniectomy is a life-saving, last-tier procedure. It saves lives by converting a rigid space into an open one to manage refractory hypertension. But this case proves that the open system comes with its own set of physiological consequences that affect the entire craniospinal axis, not just the brain under the flap.
It's also interesting to note the imaging they used. They used 3T MRI and 3D sequences to get these precise volumes. They specifically mentioned that early brain MRI showed minor post-traumatic contusions and diffuse axonal injury grade 1, but no territorial infarcts or parenchymal losses that would account for the volume shifts.
It's a very clean case in that regard. No CSF diversion procedures like shunts were performed, which could have muddied the data. This was purely the effect of the craniectomy and the subsequent cranioplasty.
The authors conclude that this case provides rare in vivo evidence that the CSF volume isn't just a result of a faucet and a drain at the choroid plexus and amalganoid villi, but is part of a dynamic system sensitive to the physical boundaries of the craniospinal axis.
It's a strong argument for looking at the whole neuroaxis. We often get hyper-focused on a head, but the spinal compartment is an integral part of the volume-pressure relationship. That 17% increase in spinal CSF volume post-cranioplasty is proof of that.
And clinically, the patient's recovery was impressive. From severe TBI and bilateral defects to entering university, it really highlights how cranioplasty is more than just a cosmetic fix. It's a functional restoration of neurofluid dynamics.
Definitely. It's a short paper, but a dense one in terms of its implications. I think we're going to see more of these volumetric studies as we try to refine our understanding of syndrome of the traphind and optimize our timing for surgery.
Agreed. It really bridges the gap between basic CSF physiology research and clinical neurosurgery.
Well, that's all the time we have for today's deep dive. Thank you for joining us on the Neurosurgery Hub podcast.
Thanks for listening. We'll link the study in the show notes for anyone who wants to look at those MRI volumetric maps themselves. We'll see you in the next episode.
Goodbye.